Good morning to all who are present over here. We thank you for your presence in this hall. We are going to start our IC on Zinging, Sensational Vitreoretinal Surgeries. We have a plethora of very august retinal surgeons, senior retinal surgeons, very accomplished retinal surgeons who are going to come and showcase important and difficult cases that they have faced and how they have managed those cases. So we, without any further ado, would like to start. I would first like to call on Dr. Paritosh Kamdar. Paritosh Kamdar is a very senior, accomplished surgeon from Mumbai. He has his own institute and he's dealt with many difficult cases and scenarios and some of the very nightmarish kind of surgeries he manages with great ease, with great meticulousness. Over to you, Paritosh, for your talk on PVR.
Very much, Karobi, for the invitation and making me a part of this course. Thank you to AIOS, APAO, Scientific Committee and Managing Committee. So I'm going to actually this case, the actual surgical steps were not so nightmarish. But there were various stages at which it was nerve-wracking. So this was a 47-year-old male and who had undergone cataract surgery for a mature cataract and poor visual outcome post-cataract surgery. So he was quickly referred for an examination and further treatment. There was a total retinal detachment and early PVR grade B. So I posted him for vitrectomy. Now the original plan was vitrectomy with encircling band and gas or oil as the case might be on the table. I make my decision about the tamponade at the end of the case, towards the end of the case. So before giving a block, I switch on the vitrectomy machine. Now my main vitrectomy machine wouldn't switch on before the peribulbar block. So the thought was, do I go ahead or do I postpone the case? Tried calling the chief engineer responsible for it, not available. I knew what was the problem, most likely problem. So the question was to do or not to do. How many of us would have proceeded with the case and how many would have postponed it at that stage? The engineer was not in town and would have become available after at least 3-4 days, and then you don't know how much time it's going to take to fix it. Would anyone? Huh? Sorry? Okay. So anyways, the standby machine was switched on, encircling band was placed, and just before the sclerotomies, just as I was applying the diathermy over the sclera, the second machine started giving some sounds, a whoosh sound, and the cutting and suction had both stopped working. So I obviously went ahead, switched plans, did a buckle. There were multiple tears in the superotemporal quadrant, and there was a more posterior break. So I placed a 280 buckle over here, and encircling band was already there. Did a partial drainage, and macula was attached, superior retina was attached. Inferiorly, there was some fluid remaining, but there was no open break. Eventually, he went on to develop recurrence of retinal detachment. Progression of the PVR, some star folds started forming, vitreous became more hazy, and then but by that time the machines were rectified, and So we started with triamcinolone assisted core vitrectomy, cleaning up of the macular surface, and there was a macular hole also. So, but before I started tackling it, I put some PFCL and did a peripheral vitrectomy, PFCL to stabilize the posterior pole. I had kept the vitrectomy engineer on standby for the resurgery. I did some ILMs, staining with BBG over the detached retina, attempted pinch peeling of the ILM, not successful. Diamond dust. The movie is in a fast mode, that's why you're seeing it rub so fast. Uh, multiple attempts were made using the diamond dusted scraper, the brush backflush needle, again pinch peel, again a repeat staining over the detached retina. It wouldn't work. So then I put some PFCL over the posterior pole and re-injected the BBG under the PFCL bubble. Waited for some time for staining, and then did an ILM peeling, which was successful this time. So apart from the PFCL helping, I think repeated staining with the BBG probably helped to make the ILM a little less sticky. Because it was a large hole, and in a detached retina, I tried to make a bouquet of the ILM. Good morning, Vaishali. And then base excision was done. This is very important for management of PVR, as all of us are well aware. And things appeared to be going very, very smoothly. And just when all was going well, there was a slip up at my end, and the chandelier illumination that created an additional break plus a bleed both in the ciliary body as well as in the retina. So the clotted blood was removed, and just when I thought things are going okay, my curved endolaser probe poked the retina, but that was also managed. And then finally readjustment of the flap over the macular hole, and just as things were going all right, I mean, there was fluid gas exchange, I started injecting oil, and you see there's this cloud which appeared behind his IOL. Anyways, it all came out. It was basically the condensed triamcinolone over the uh, posterior capsule and the peripheral anterior vitreous behind the IOL. Air bubble into the AC, Baracker's tonometer for checking the pressure. That was good. 6 weeks post-op, vision improved to 624 and 8 partial. Patient's wife had to be recounseled. She was expecting 6 and 5. So lessons learned. Learn to think on your feet. Know your machine well. The first machine conked off because the BIOS battery had gone off. Even the simplest looking cases can land you into complications, and one needs to spend significant amounts of time pre-operatively to counsel the patient and attendants, and one needs to keep one's orchestra of armamentarium ready, because who knows what might happen and when in PVR surgery. Thank you very much. Murphy's Law, yes. Thank you, Karun.
So all's well that ends well, and we are happy that he recovered 624 vision. Are there any questions for Paritosh? Vatsal, I thought you had a question. Okay. We go on to the next speaker. Next speaker is none other than Vishali Gupta, and she's here to give us a keynote address on 27 gauge vitrectomy for diabetic retinopathy. And she needs no introduction. She's such a prolific person from this PGI Chandigarh, and she's well known not only in India but all over the world. So if I say Vishali in some corner, everybody will know her. So over to you, Vishali, for we want to hear you.
Thank you, Kerobi, and sorry, I don't like to be barging in, but I was just given this topic. Well, I won't speak for very long, I promise, Kerobi. So I will be speaking about complex diabetic vitrectomies using 27G. So it's an instruction course. So there are few tips. I don't know. इसको थोड़ा उधर move कर दो. The first thing is choose the right instruments, because there are port-based flow limiting factors which you have to keep into consideration when you are doing 27G. 27G has ability to work close to the retina, which means you get more access to tissue planes. And when we look at the distance between the port and the tip, port is actually close to the tip, so you can get a vertical access, and the smaller diameter allows a lateral access to the epiretinal membrane. Segmentation and delamination are the two crucial components of diabetic vitrectomy. So when we are using these cutters, we can do actually mono instrumentations, and it reduces our dependency on needles very significantly. They also have ability to manipulate tight adhesions in mid-periphery, which helps both in fold back and conformal delamination. Now let's see in real world how this helps. This is a typical diabetic vitrectomy. I'm sure in this IC you will be covered majority of these. So when you have cleared the vitreous, and typically in the mid-periphery you would have these adhesions where it is going. You don't have to change instrument. I don't remember using scissor for such a long time. What you can do is you can actually insinuate the tip of the cutter. You can use proportional reflux little to delaminate and then start separating these membranes from the surface. There is high cut rate which reduces the surge and pulsatile vitreous traction, and conformational delamination, which means that when you introduce, you can do proportional, then this node you can go close to it, you can cut it, and this can be made to follow the retinal contour. You don't have to go beyond. Sometimes the cases are more complex, like this one, lot of this. So this is what is fold back delamination. With the same cutter, actually I find it very useful, because you can move it in any direction. You can go from the side, you can do the fold back. Fold back is you put the cutter behind, and this lamina kind of folds into the cutter and you can cut it. But what I like is sideways cutting also. So you just move it and you can start cutting in whichever direction you want, which is a big advantage out there. Tackling the fibrovascular proliferation in the mid-periphery. Now this is something we all understand can be a bit tricky in diabetics. Sometimes I just use a little forceps, like I said. This is not to peel, this is just to nudge, to be able to find that little niche through which your cutter can go. And with the help of the cutter, and you can use 27G Sharskin forceps to separate, and the micro laser etched pattern in that forceps helps in the delamination. So this is conformal delamination means you are conforming with the contour of the retina like this, and you are peeling these membranes from the surface of the retina. This is what I do with the forceps, just to lift it a bit, because in the mid-periphery, using proportional reflux to lift it is very difficult. So I use sometimes a forceps, and you can see that all the mid-peripheral traction which was there is gone. Similarly, you go to another area, you insinuate the cutter, use the proportional reflux to separate it, divide it into segmentation, and then each segment can be cut very nicely using the conformal delamination. You really do not need. Where it's very firmly adherent, little forceps with the nudge, and then you can remove these small islands very nicely and separate it just using one cutter only. So this is the same patient pre and post-op. This cutter also allows the excess segmentation because you use, and we do have eye microscope integrated OCT, which can help you actually show you where the tissue is, where your cutter is insinuating. But I personally do not find it that useful. It can just confirm, but this microscope does not really guide you. If you want to do bimanual surgery for some of these complicated cases, I think 27G you can still use, and I use it generally. I hold it. The forceps is being used, but instead of using the scissor and all, you can use the same instrument to delaminate, to cutter. One just has to be very careful about the cutter related breaks, and that you will learn with time, because you may use proportional, linear, whichever, or even 3D vitrectomy, but that is something which has nothing to do with the gauge. That is something more to do with the experience. But you can simply start using cutting it, holding forceps in one hand and cutter in the other. PVD induction. 27G actually has better ability to engage the posterior vitreous near the retina, and you can do it nicely. I'm not here to advertise 27G, it's just any small g, and I have no financial interest. OCT, you can use OCT or dye or anything to identify some of these residual membranes which might be on the surface, and then take time to release them, to separate them nicely, because this patient we were doing vitrectomy for diabetic macular edema. So make sure that you have nicely peeled off all the residual membranes, and there is no tangential traction even after doing the PVD, because PVD will take care of the AP traction, but the tangential traction will come from the secondary membranes. And this is probably my last video, which is just to show you that how this TPHM is there. You can see it on the OCT intraoperatively on the sides, and you can use the same OCT to confirm whether your peeling is successful, if anything is left or not. But you don't have to lose heart if you don't have OCT. You can do it very well. As a clinician, you know when you have removed, and you can use the dye to confirm that everything has been peeled off and nothing is left. So this is the last video, just to show that it's a small, delicate, multifunctional, but using the same instrument. This is something we call minimal PVD from the disc. You just insinuate the plane. You don't go all the way. But once you have the plane, I think this cutter and these vitrectomies have made the mono instrument diabetic vitrectomy very simple. You can just keep going, keep peeling. But one thing which I haven't shown here is you have to take care of the bleeders along the way. It can be used to aspirate the blood which is on the surface, but if you find a bleeder, then you have to move it along the way. Take care, don't allow the blood to coordinate, coagulate because that is the fibrin. And this is what I meant. Like you can keep on moving the direction, which I think scissor doesn't give you that flexibility. You just move it, you cut it in that direction, you move it, you cut in this direction, and these thick membranes, you can easily handle them if you learn to maneuver your cutter properly. So I will move it forward just to show you how the dissection is being done in all the quadrants, the whole surgery with the help of a single instrument. You don't need much. And if you have injected pre-op anti-VEGF, the bleeding is actually very minimal in these patients. So this is the last. So I will not go much into this. I promise, Karobi, I will finish on time. And thank you very much for allowing me the.
Thank you, Vishali. Just a moment. Thank you, Vishali. That was an excellent presentation. We felt like going on and on. I mean, we could have finished the entire IC with only your videos. But the thing is that excellent. I mean, what you made look so simple is actually in the hands of a newcomer could be disastrous. Yes. So,
Yes.
Paritosh, you had a question for her?
I second what Karobi said. I think it was
Take
just
that.
a three.
Take that.
Watching the video, then we could have continued.
Thank you.
Just a question about the 27 gauge, that beveled probe. Are there any instances or risk of it poking the retina while you are attempting to go under and creating some?
You can actually, this talk was 27, but you can do the same things on 25. In practice, my 80% of the surgeries of diabetics are on 25, not on 27. So you can do it with both. I don't find any this. Like now with 20,000 cutters also, whenever my patient can afford, I love to use them for diabetics. Only for diabetics, I don't use them for this. But 25 works equally well.
The bevel does not poke the retina or
No,
anything.
no, no.
Excellent. Any other questions for Vishali? You rendered them speechless. I now call on Dr. Vatsal Parekh. Vatsal Parekh is a very senior vitreoretinal surgeon from Mumbai. He has his own Drishti Eye and Retina Center over there, and he's almost 40 years into practice of vitreoretina, and he does it with a passion. And he's operated a lot of very, very difficult cases with a lot of ease. Let's go over and see his cases.
Good morning, Karobi. I thank you for inviting me to this course. Now, I'm just going to show some tricks of vitrectomy. Now, this patient has a injury, is a young boy about 12, and there's a macular pucker. And there's a bad chorioretinal scar here and inferiorly. This is the OCT, and you can see the tip of the membrane here. And this is the post-op OCT. Now, instead of doing complete vitrectomy, what I have done is just peel the membrane over the disc and up to this area. And this is 1 month post-op. The patient is better anatomically. Now, this is the video. This was the area where the membrane was lifted. So I'm lifting with end gripping forceps. And instead of doing extensive PVD, I've just restricted surgery to the posterior pole. And I'd operated similarly another patient of chorioretinitis scar outside the arcade with macular pucker and done limited vitrectomy and pucker removal and limited vitreous detachment. And subsequently patient had phaco, and this is almost 8 years that patient is doing reasonably well, and maintain 6/9 vision. So just going over the posterior pole, lifting it, it will get lifted from the optic disc also. Gentle maneuvering, repeated maneuvering is important. If you pull too hard, you may create a break here. So just be gentle and be repetitive in action. And once this is lifted from the optic disc, I have done core vitrectomy without dissecting anything at the base or trying to induce PVD, because if you induce further PVD, you may traumatize the retina more. Anatomically, patient has done well. This is 1 month post-op only. So visual outcome, I don't know. Now these are 2-3 cases I wanted to show of myopic eyes with retinal detachment. This is pre-op and this is post-op. Now if you see the surgery, there's a lot of vitreous haze, vitreous floaters. So we do core vitrectomy. There's no obvious, you would assume that PVD has occurred since there's so much of vitreous which is here opacities. There was the inferior detachment. You do base excision. Now after doing this, normally one would do PFCL or create a retinotomy if break is not seen, and finish the gas with oil or something. Now here you see there is extensive myopic staphyloma here at the posterior pole degeneration. So what I have done is that after this put, now vitreous is, a lot of vitreous is out, and this is the picture, this is the detachment. So instead of stopping here, what I have done is injected orocort or triamcinolone powder, and once you inject triamcinolone powder, you will see the vitreous schisis. Can you put off the light? I think it will be better. Can you put off the lights, please? So here at the macula there was some epiretinal membrane, and once I remove it, there's a edge of the vitreous schisis here, and you can see that that edge is got lifted. And entire posterior hyaloid to a great extent came just with forceps and occasional use of cutter. Now this is translucent posterior hyaloid. I believe that there could be breaks, micro breaks at some of these areas where vitreous is firmly adherent, and which could have led to retinal detachment. So using triamcinolone powder was a key in this patient to detect this. Otherwise, if one uses silicone oil, retina would remain attached, there would be inferior detachment shallow, and if one uses gas, then probably it would redetach, and one will end up with resurgeries and retinectomy and other things. So this posterior hyaloid or vitreous schisis was seen after injecting triamcinolone powder into the vitreous cavity, and I have used only C3F8 gas as tamponade. You can see again here. So then after removing this, it was regular FG endo laser. Now what I have observed is this patient, myopic patients, I think RP is abnormal. This patient on day 2 had inferior detachment, and I was thinking that we'll have to do buccal because this was only C3F8 gas with vitrectomy. But this settled without any surgery. So probably myopic eyes, the RP is not functioning well, and this was transudative or exudative detachment, and this is the final post-op vision result when retina was nicely attached. Now this is another case, again high myopic, inferior detachment. I had initially buckled thinking that there is no break, but buckle didn't work, so this was the vitrectomy which was done, and again same way, there is no obvious PVD here, only vitreous haze. So I did base excision. And at this stage, what to do next? So I injected in this patient also. You see inferior detachment. There is no PVR. Retina is smooth. There was no obvious break. One could use PFCL and settle this retina, but instead I have now this is after triamcinolone. There was a little powder which was stuck here and something was coming. So I peeled that membrane, and this is the membrane edge or that posterior vitreous schisis. Now I'm injecting here triamcinolone. Now when you are removing it with flute needle, if there is a loose vitreous cortex, you'll get it something coming into the flute needle. So you start peeling there, and you see how entire posterior hyaloid gets detached, gradually. You need patience and perseverance because you might have to stage second time with orocort also. Now this patient had similar detachment in other eye in 2005, and I had not used orocort, and I had to do 2-3 surgeries to settle it. Just put off that phone. So this inferior detachment again, there was post-op which settled with time, and this is the final picture. Retina was nicely attached. So probably there is element of transudation also, and this is the last patient who had myopic detachment. And now after core vitrectomy, this looks here like regular detachment, mobile retina. You see for the whole, if you don't see, create a retinotomy or PFCL injection. But here again, as I showed you, I am injecting triamcinolone powder, and you'll see what is happening here. You see this entire posterior hyaloid is seen so well now, which was not visible earlier. So just a simple use of triamcinolone, I think in practically all patients will make the difference, in completing the vitreous surgery, removing the posterior hyaloid. Now what is important is here you feel this is all hyaloid, but there is retina behind, because this is a myopic eye, so retina is thin, so you have to be careful in cutting. So I am limiting dissection at the posterior pole only, and eventually you'll see that the behind is retina. I am able to leave this hyaloid all round. This behind, what you see here is retina here, and the hyaloid is here. So try to remove as much as possible without creating breaks. Breaks can occur, but all the patients what I have shown have done well with the surgery. This is operated just 3 days back. So I have yet to wait for the result. So basically what I am advocating is that one should use triamcinolone powder during vitrectomy, at least for detachment cases. It will show you what you never saw before. Thank you for your patient hearing.
Thank you, Vatsal. That was a real sort of basket of lovely cases that you did show us, and the possible complications which only a very experienced surgeon can do. There are any questions for Vatsal?
With the limited vitrectomy you showed, sir,
और ये चालू करो
what are the
मेरा।
chances that
इसका full
you
screen
can
कर देते
create
हैं ना?
tractional events in the periphery?
पता नहीं।
See, this is I think third patient I have done. So I don't find any adverse effect. Probably what happens is that these are inflamed eye. So rest of the vitreous is quite condensed, Because this is traumatic injury. Other patient was chorioretinitis scar. So till now,
Brightness
not much
of the
problem.
eye.
Theoretically, yes. But what happens is that if you try to create PVD on table, you will definitely create breaks,
And the other thing is, once you leave a significant amount of vitreous it quickly organizes and becomes more hazy.
I'll send you the photograph of the first patient who is following up for 8 years, you know. It looks quite good.
Quite.
I'm not very big series,
It,
but limited experience.
thank you.
Correct. And traumatic scar which was so bad.
You have connected?
Any other questions?
Yes, ma'am.
Okay, if there are no questions, then I go over to my talk. I'm also having a series of different etiology sort of cases which I thought would interest you because the name was Zingling and Scintillating. When I was talking to Paridosh about this, he told me that he's going to show a case which is not dramatic in the terms of
Thank you,
dramatic,
ma'am.
but dramatic in the course of events. So I told him, see, either you have a yow reaction when you go ahead and do a vitreous surgery, or if it is a difficult surgery and you land up in problems, this is what you do, you shed bricks, you know. Okay, so let me start with a wormy beginning. It's a 56-year-old man who was fishing in the mangroves, and he came with the complaints of a lump under the conjunctiva at 11 o'clock meridian, and he also said that he could see a wriggling object in front of his eyes whenever he moved his eye. So we examined him, and there was a lump over here, and when we checked the retina, he had a worm in the retina, so we thought that this would be probably a worm in the upper region too. So the surgery then was done for this patient, where we had to remove the worm from the front part also and from the back part. So this is the removal of the worm. It's always very exciting when you have a worm to remove because it adds another dimension to your surgeries. The normal kick of the surgery is what gets your adrenaline up, you know. So lo and behold, this is a worm which is very long, and this was a lower worm which is it's transmitted by flies, and it's the chrysops fly which transmits this, and this is very common in people who are generally in marshy regions. So in mangroves, etc., this is very common, and this has a kind of transmission through subcutaneous route, and it can migrate through the subcutaneous route. It was there at the ciliary body also, a small worm, and the worm you saw was in the eye also, which you can see wriggling inside. So this was removed successfully and sent for detection of what is the kind of parasite that you're dealing with. Now the second kind of case is that this patient had a 6/6 vision. He had a history of foreign body injury. The scleral perforation had self-sealed. There was just a fine trickle of blood which let you know that there is some kind of a problem at that site. There were no retinal tears. And when the x-rays and the CT scan was done, you saw a small foreign body in this location. Very difficult to move it with vitreous surgery, and if you have to, you'll have to sacrifice the lens and then put in an IOL and then try to remove it, which would be a messy job. So the thing is, the whole thing was to try to remove it without disturbing the vision. So this is where you have to think out of the box, where you have to do something which is probably unconventional, but you go ahead with it. The important thing that the end result is what should be desirable. So a small flap, according to the site of the foreign body, was made in that location, and you made another flap inside so that you have a area to cover it. And this is the point where you cauterize it and make a small nick. And since the foreign body is just lying underneath it, you can just go ahead with your forceps and pick up the foreign body. It was a small stone foreign body which had gone in. And you do a vitrectomy, do a little bit of cryotherapy, and suture back this incision. Now, this case I will keep for later if there's time. Okay. Now, this is a patient of a 65-year-old. She's a diabetic, hypertensive, had cholesterol issues, and CABG was done in the past. She was on antihypertensives, anti-diabetic medications, on statins, and double blood thinners. So she had a cataract surgery for a rock hard brown cataract. She had a nucleus drop following vitrectomy, and the PFs and following vitrectomy, and then the nucleus was removed with the PFCL, and this at the end of the surgery, this at the end of the surgery, she developed a suprachoroidal hemorrhage, as you see in this video. It was a hard nucleus which had dislocated inside, and with the use of PFCL and doing a vitrectomy, you take it out of, you enlarge the incision and take it out. It was a really messy kind of a scene. Replace everything back, suture it back, but at the end of the suturing, you see suddenly a gush of red blood appears, and there is red mounds appearing within the eye. So you close up, you wait this, an ultrasound was done which confirmed a huge suprachoroidal, as you saw in the previous slide. And then after 14 days, you go ahead and do a suprachoroidal drainage of the blood, and the retina was slightly lifted in one place. So you do the vitrectomy, remove off all the membranes, and I used a buckle in this area because there was a tiny break in that location. Now, this is another patient who had a suprachoroidal bleed somewhere. She had one surgery which was done elsewhere, and the patient was doing well, but later there was some residual blood, and then the patient developed a giant retinal tear, which was like sort of very scrolled and almost looked impossible to do. But the surgery was carefully medically done. That is, there were a lot of subretinal gliotic bands, as you see over there, and these were carefully removed. One really never thought there was a chance in this patient to do well, and the blood was suctioned off from its place, and then slowly after PFCL injection, you find that the retina is settling in the posterior pole, and after doing a retinectomy in the periphery, the ILM peel was carried out, following which all the a retinectomy was done, and then the retina was lasered, and we had the patient with a small island of retina all around the optic nerve where the macula was good, and this patient did develop 660 vision following the surgery. Now, this is a preterm born. How many minutes left? Okay. Preterm born, and this was a 28-weeker, 890 grams. I was not examined at all, and they came to us at 8 months of age. The patient had a 5C ROP with corneal opacification, shallow AC, and a completely closed funnel configuration. This was how the ultrasound looked, and this was how the eye looked. And we kept a graft ready for the patient, and we decided to do an open sky vitrectomy for this patient, where you see the thickness of the cornea, and after the Fleringa ring was put, and after you remove all the membranes, we tackled the periphery because there was a closed loop configuration there, and very slowly, meticulously, all the membranes which were binding the layers of the retina together were slowly removed, and all the time you have to keep injecting your upper visc or agent for sort of separating the layers, and slowly and surely you find that the retina is opening up. The center has already opened up, and then you go ahead and there are no dynamic placements in stage 5 surgeries. You just have to open and leave it alone to go and take its natural place into the back of the eye. And this is at the conclusion where you finish off with this and then suture this back and await events. This is another patient who had a retrolental membrane. This is a NETA case who was not injected, so the dissection in these patients become very easy, where you can see what you're doing, and there is a gradual delamination of the layers, of the retrolental membrane from the surface of the retina, and slowly you do it circumferentially, where you keep separating and go ahead and separate all the layers. I'll fast forward it, and this is like we've done quite a bit of it, where you're separating, delaminating, and this is towards the end where you have opened up the central sheath and the retina just falls back. The important thing is that you have to open up the peripheral trough. And stage 4 case ROP, where you need to remove only what is causing traction. Here you don't really go vociferously after any of those very taut membranes, which sometimes have been created by the use of anti-VEGFs in the eye. So whatever is the traction, leave the macula free, and you can close up the case without really because these cases do well with that minimalistic kind of surgery. And this is another patient where you could skip a beat, because when you're removing the thing, the cannula remains behind in the ciliary body region. So you go ahead, pick up the thing with a forceps, and when you try to remove it, it comes, the enlargement has not been done, so it gets stuck at that site. So you go ahead, enlarge it, and reintroduce the forceps again, hold it properly, and then it comes out. So finally, all's well that ends well. So the moral of the story is never give up. Thank you. I now invite Shilpi to come and give her, she'll show you beautiful videos done on Ingenuity, and it'll be a treat to see. So she and Prashant have been kept for the last, along with Dr. Somil, who's not here, but he sent his presentation. So I'll play it after Shilpi's. She's from Sarakshi Netralaya, and she and Prashant are working together.
Thank you, ma'am. Good morning, everyone. Thank you, Karubi ma'am, for this wonderful opportunity. So I will be sharing my top 7 pearls for managing giant retinal tears. So we all know giant retinal tear is always a nightmare for any vitreoretinal surgeon because of the less chances of success. So in giant retinal tear, we all know that it is more than 3 clock hours of the retinal tear. Edges have the tendency to roll back, but yes, with the advancements, we have improved success even in cases of giant retinal tears because of the wide angle viewing systems, use of PFCL, smaller gauge vitrectomies, high speed cutters, and vault cannulas. So the pearl 1 is PVD, that is posterior vitreous detachment. It is usually present in all the cases of giant retinal tears except when there are cases of trauma or familial vitreoretinal degeneration. So this is a case where PVD was not present and there was no space. So initially you need to create the space by draining out the fluid as much as possible, remove the membranes over the posterior pole, and then when the space is created, PFCL is put and the case is closed. Second pearl is base excision. It is very important in any case of retinal detachment, and especially in case of giant retinal tears. We should always use high speed and low vacuum while doing the base excision. Base excision can be done by the depression also, and the interface excision also. In this case of GRT, we not only do the base excision on the area of the GRT but also in the other quadrant, so that all the traction is relieved. And if you feel that some traction is still remaining, you do the base excision, especially in the area of the giant retinal tears, and the rest of the retina and the vitreous is cleared. Third pearl is management of the anterior flap. Why anterior flap is management is important? Because it is a devitalized tissue which is a scaffold for the anterior loop PVR, and it causes rubeosis. So we can manage it in two ways. We can excise the flap or we can laser ablate it. So in this case, the anterior flap, it was excised because it is a devitalized tissue and it is of no help. And if you feel that you cannot remove the full flap, you can even depress and then remove the flap. Despite that, if you have done the meticulous dissection and you have tried to remove the anterior flap completely, but sometimes there is some tissue remaining despite of the meticulous dissection, and in that case you need to laser the remnants of the anterior flap so that it will not cause rubeosis or the PVR at the later stage. Now coming to the fourth pearl, that is the unfolding of the retina. In many cases when there is a large GRT, there is like you can see here that there is the retina is folded on itself. So after unfolding you can use PFCL. It should be injected over the disc as a single bubble till edge of the GRT, and you always have to tilt the eye in the opposite direction so that the SRF is drained. So these are the cases. In this, it is almost 270 degrees giant retinal tear. After unfolding the retina with the two instruments, that is the light pipe and the cutter, the PFCL was put as a single bubble over the posterior pole, and after it is flattened, it was managed as a routine GRT case. Despite putting the PFCL, there was a retinal fold in the periphery. So we can use the ILM forceps or the soft cannulas or the blunt tip of the forceps so that we can unroll the flap and after unrolling the flap, we have to complete the case as a usual case. So in this case, there were membranes. So after removing the membrane, PFCL was put. Again, the anterior membranes were dissected. If needed, we need to do retinectomy so that we can flatten the retina and then the case can be completed. The fifth pearl is how to do the laser. So retinopexy is most important, and we have to use the moderately intense burns. It should be near confluent and always 3 to 4 rows of the burns should be given. We should not leave the horns or the radial extensions and always put the extra rows of lasers in that case. Usually in cases of GRT, the endo laser we usually done under the PFCL because there are less chances of slippage of the flap. So there was the horn left and the anterior flap also, which is being lasered. Now, how to prevent the posterior slippage? So always avoid high and broad buckles. You should always put the PFCL up to the edge of the GRT. Meticulously, we should remove all the subretinal fluid. In that, you have to rotate the eye in the opposite direction or the dependent position so that it removes, and always do the repeated drainage along the edge of the GRT. If needed, you can do PFCL silicone oil exchange, but if you have done your lasers well, if the retina is well flattened, even the fluid air exchange with the silicone oil exchange is equally successful. So these videos will show how the drainages along the edge of the GRT is done. Always remember, never cut short this step. This is one of the most important step. You have to give extra time while draining the fluid along the edges of the GRTs. you have to repeatedly do the fluid air exchange so that the last bit of the fluid is removed. Even in cases of 360 degrees of the GRTs, we have never done the PFCL silicone oil exchange. It is always the fluid air exchange and the silicone oil exchange. Now, you always have to tackle the concomitant pathologies also, like like ERM and macular holes. So after putting the PFCL and staining the ILM with the BBG dye, the ILM was peeled under PFCL and the case was completed later. And this is a case where there was a macular hole. After relieving all the anterior traction and creating the space, the ILM was stained, fluid was drained, and similarly the ILM peel was done and the case was closed. But remember, many a times it's not your day. Even after meticulously dissecting all the membranes, clearing all the anterior flap, doing the lasers and everything, there is some kind of residual things which are left. Like if you see that at the end of the case there is some fluid pocket over the macula, but don't panic. Over a period of time this fluid resorbs and there is no recurrences in such cases. In this there was a slippage of the flap and the PFCL bubbles went besides the retina. During the fluid air exchange you can remove this PFCL bubble and again put the PFCL later on and complete the case. And in this case, even after removing the complete PFCL and the fluid exchange, there was a little fold over the posterior pole at the last. But after putting the oil and giving the proper position, these folds later on they get settled. So thank you so much.
Wonderful cases, Shilpi. It was a treat to see. Only thing is that tell me that when you're working on the ingenuity, do you have a learning curve?
Of
Or
4,
is
5
it like
cases.
cakewalk, like you go in and you see a large thing and it's very
Ma'am,
easy?
it's only a learning curve because of the lag, and it was only for a 3 to 4 or 4 to 5 cases at the max.
Okay, okay. Because the thing is that every new thing you have to adapt to it. So I just wondered like what would be the adaptation to the ingenuity. Any other questions? Come to the mic. And you said that after doing these things meticulously, if still there is something remaining behind, blame it on the patient's karma.
I'm sorry, good morning. My
Good
question is
morning.
regarding the ROP, open sky. How do you maintain the vitreous cavity during those times of
Sorry,
during the time of open sky
yes,
vitrectomy in ROP stage 5?
yes.
How do you maintain the vitreous cavity?
How?
Maintain the vitreous cavity. Do you
I had put a Fleringa ring around it. I had put a,
viscoelastic. You use viscoelastic.
I put a Fleringa ring first. If you saw the Fleringa ring which was there,
Okay.
so I had sutured that onto the sclera, so it holds the eye up like a embroidery a thing, you know. I mean, the band which is there, and then the assistant has to keep injecting PFCL, not PFCL, this
Viscoelastic.
viscoelastic substance every time you're this
You
and
dissect.
yeah, inside the eye.
Okay, thank you.
In giant airs, before you put the oil, you shift to air from
Yes,
the
sir.
PFCL, or you do direct PFCL
No
oil
sir, no direct PFCL or silicone oil exchange. It is always PFCL air exchange and then the silicone oil.
No, but you can do PFCL
Yes,
silicone
sir.
oil exchange. That sometimes solves the problem of repeated slippage.
Mhm.
And also the edge can be very stiff and there can be edge PVR. So some radial nicks at the edges sometimes will help it prevent roll.
Preventing
The edge may not roll that much.
That is the reason why if you have worked with the stalwarts like Dr. Badrinath and all before, they used to do the giant retinal tears in prone position where they used to be sitting under the table and doing the air injection so that, you know, it falls into place like an umbrella.
when the retina becomes stiff, that will happen, and shortening. So even after you have put PFCL, it won't go and settle in its place because it is shortened. Then you may have to give radial cuts. Be sure that you have done laser at the posterior end of that radial cut. Otherwise, it will extend and you will be in trouble.
I've seen Dr. Badrinath do a buckle at those radial edges of a 90 to 100-degree giant retinal tear, and it settled.
It settles.
Yeah. So it depends upon whether it's a fresh GRT or it's
Old
one
GRT,
with PVR. So in a fresh one, normally doing a good base excision is the most important thing, particularly at the edges. So either you relieve traction from inside or outside or both. And when it's a PVR, then of course you treat it like any PVR, and then you may extend the GRT also and do retinectomy or whatever. So remove all the contracted part, because there are two elements to PVR. One is the membranes on and under the
Paritosh, speak
band.
into the mic.
And the other is basically the intrinsic contracture of the retina. For intrinsic contracture, you'll have to cut the retina. Others? Yes, so there then you have the choice.
Thank you, Shilpi. You have to come back once again after I finish filling in for Somil. Wonderful cases, and we'll see more wonderful cases from Prashant's side by Shilpi after Somil's talk. I am doing this talk for Dr. Somil Seth because he's not in the country, but he's been kind enough to send his presentation. Somil is a very, very accomplished surgeon, and he does all these very dangerous, deadly cases with a lot of ease and elan. Let's go over and see what he does. So the first case is a case of a central retinal artery occlusion which he's tackled. There's a voiceover, so you can hear him say what he has to say. Volume करते ना.
Vitrectomy less than 24 hours. A 75-year-old female with a known history of coronary artery disease
Can you hear?
presented with central retinal artery occlusion of 18 hours duration. A cigar-shaped embolus extending along superior and inferior arterioles was noted in the optic disc area. From its physical appearance, it appeared to be a cholesterol plaque. Began by performing a 23-gauge plasmina vitrectomy with
1
PVD
minute.
induction.
Can't hear ना.
Internal limiting
आप connect कर दो. Okay, I'm going to start this.
means to relieve a central retinal artery occlusion, especially when operated upon by vitrectomy less than 24 hours. A 75-year-old female with a known history of coronary artery disease presented with central retinal artery occlusion of 18 hours duration. A cigar-shaped embolus extending along superior and inferior arterioles was noted in the optic disc area. From its physical appearance, it appeared to be a cholesterol plaque. Began by performing a 23-gauge pars plana vitrectomy with PVD induction. Internal limiting membrane peeling was performed as an added measure to improve foveal oxygenation, at least theoretically, as some reports mention, in case we were not to succeed in our embolus dislodgement. ILM comes piecemeal and care needs to be taken to avoid trauma to boggy nerve fiber layer. ILM is peeled in the peripapillary area to aid physical contact maneuvers with the artery. A cigar-shaped embolus extending along superior and inferior arterioles was noted in the optic disc area. This maneuver, creating low pressure in the vitreous cavity, may enhance arterial pressure gradient, forcing the embolus out. So we clamp the infusion port and give active suction to aid the arterial pressure to push the embolus forward. Hypotony endpoint being disc elevation and development of peripheral choroidals. Maneuver 2. to surgical deangulation of the arteriolar bend for the emboli to get released along a straight path. We pinch and pull the adventitial sheath of the vessel as well as straighten it out. This teasing can either dislodge or fragment an embolus. As we see the embolus migrating distally, complete filling of the vessels is taking place behind the embolus, restoring retinal circulation on the spot. Those who missed it, let's do it again. We would like to describe this process as the most extreme form of digital massage of the CRO that can be possible, as it is performed directly on the vessel. Next attempt at arteriolar teasing releases embolus fragments along two superior arterioles. For those who missed it, let's do it yet again. Viewer 3 milking and pushing the embolus along the vessel. While dislodging the inferior embolus does migrate but stop short at the fovea. This should be okay as macular circulation has already been established and we need no further maneuvering. Circulation, as we see, is finally restored and
beautiful case. Vision recovered to 618, which is good. His next case is, he's one person who really thinks out of the box. So this is about a subfoveal plaque.
our case is a 65
of hard exudates.
year-old diabetic and hypertensive female with best corrected vision of finger counting 2 to 3 meters and a history of multiple intravitreal injections and steroid implants in the past, presenting with a subfoveal hard exudate plaque in an otherwise dry macula. Her OCT shows the plaque to be located intraretinally or specifically within the outer plexiform layer of the fovea rather than subretinally, which is between the photoreceptors and the pigment epithelium. Conventional surgical approach involves poking the retina in the paramacular area with a 41 gauge needle, inducing a localized iatrogenic foveolar retinal detachment with saline injection, and then going on to aspirate the hard exudate plaque in the outer plexiform layer. In this process, one passes through all the foveolar retinal layers, causing potential damage not only to the pigment epithelium but also the neural elements, namely the photoreceptor outer segments and nuclei. This collateral damage may result in poor visual outcomes. My surgical approach involves aspirating the hard exudate plaque from the top of the fovea after poking through just its inner lamella, creating a lamellar or partial thickness iatrogenic macular hole. Thus, apparently poking where it hurts the most in the eye could actually be the place where it will damage the least, as my technique incurs potential harm only to the Mullerian cell cap and no neural elements, as no neural layers exist beyond the outer plexiform layer at the fovea. As seen in OCT and histology, we are using the unique foveolar anatomy to our advantage, as by poking from the top involves much lesser neural tissue interference than that incurred when approaching from the bottom, leaving us with a macular hole lamellar in nature, which post internal limiting membrane peel will close like any other macular hole. As in any vitrectomy surgery, the first step is PVD induction, during which we realized it is a proliferative retinopathy and bleeders were pressed with vitrector for hemostasis. After staining with brilliant blue dye, the ILM was peeled in order to close the iatrogenic macular hole that will be subsequently induced. typical in diabetics, ILM is tightly adherent and was peeled piecemeal. Alternatively, ILM flap could have been made for better closure of the macular hole. Light separation at the top of the fovea will possibly hurt only the Mullerian connective tissue and not the neural elements. Hard exudate plaque was then aspirated, leaving an iatrogenic lamellar macular hole that will close like any other hole. Laser with air fluid exchange was performed, followed by gas injection and prone posturing. Post-operatively, good visual recovery was noted with type 1 hole closure.
After that second case is his third case, which is a case of Coates disease. There's no voiceover in this, so I'm going to fill in for him. He goes ahead with a cataract removal first because this is a very highly elevated exudative detachment that you see. And after completing the cataract, he puts in a lens implant. In the bag, dials it into place. Then he goes ahead to fix a AC maintainer, and at the height of maximum fluid, he goes in and aspirates the fluid. You can see the yellow fluid coming into the syringe. And visualization is carried out where he sees the fluid generally reduce and the retina go back. What normally happens in these cases, a lot of hard exudates also escape along with the exudative fluid. So there's generally a reduction in the number of hard exudates which is generally there. And with this vitrectomy, he just goes ahead and the areas which have the telangiectatic vessels, he's doing laser for those areas. And then a fluid gas exchange, and he settles the retina. Looks near normal now, except this part has to shrink off. Thank you from Somil's side, and now I call Shilpi back again. Dr. Prashant was supposed to be here, but he's got a viral fever, so he's not this, but he sent his talks, and Shilpi will be talking on behalf of Dr. Prashant Bavankole.
So good morning once again. So now I'll be speaking on recurrent macular holes. So by definition, what is persistent or refractory macular hole? It is the failure of the hole to close after primary surgery. And what are recurrent macular holes? They reopen after the successful closure. The incidence is 4.8 to 9.2%, and usually the timing of recurrence is 12 to 15 months post first surgery. The various causes are found, and the most important causes are that in cases of pathological myopia, there are high recurrence cases. If there are intraoperative retinal tears which are not managed or addressed properly during the first surgery, they can contribute to the opening of the macular holes. Cystoid macular edema due to any cause, be it after the cataract surgery or any of the reasons, it can lead to the reopening of the macular holes. Post-surgical complications, recurrent epiretinal membrane can pull the macula and create a recurrence of the macular hole, and leftover traction by the vitreous is the another cause for the reopening of the macular holes. So what are the treatment options available? If the macular hole or the retina is patulous or elastic and pliable, you can simply drain the SRF or do the hydrodissection or can use the autologous serum. But if it is associated with the PVR, we need to address that issue also. We should remove the star folds. If needed, we can do retinotomies, retinectomies, and even in the GRTs, we need to do the relaxing retinectomies. Now coming to the grafts, we can use the ILM graft, retinal grafts, amniotic grafts, even the lens capsular grafts. And in the last resort, when there is nothing to do and RP is very unhealthy, so as a last resort, you can even do the endolaser to the edge of the macular hole in cases of the recurrent cases. So what to do when the residual ILM is present? So this is a case we always stain, put the BBG before proceeding for the surgery in a hope that there is any residual ILM present there. So in this case, there was the recurrent epiretinal membrane and the ILM was not peeled. So it was used and the inverted flap technique was done. So in inverted flap, ILM flap remnant, it's the hinge to margin the macular hole. Even if you have a little bit of the ILM remaining, you can use it to invert and fill the gap. So various modifications are done, like even you can use the autologous platelet concentrate over the ILM flap. Texas taco technique also can be used, and you can also use the nerve growth factor so that the surgical success is increased. So this was another case. She had the recurrent macular hole, and after staining, we could see that the inferior ILM was not there, but superior ILM was there. So the ILM was peeled and the flaps were made. An inverted flap technique was done, followed by fluid gas air exchange and the tamponading agent. When ILM is not present, so what are the options available? You can do the hydrodissection. I'm sorry, we don't have the video of this. In this, we use the balanced salt solution and it is injected all along, in the 4 quadrants around the macular hole. You have to create the bleb so that it pushes the retina, it makes it more pliable, and following fluid gas exchange, the macular hole close. You can also do the relaxing retinotomies to release the tangential traction, but there is higher risk of vision and visual field loss with this technique, and this is usually reserved as a last surgical options where all other options have failed. Autologous ILM transplant is used when there is no ILM near the macula. Preferred site of harvesting is within the vascular arcades. Major challenges is keeping the free ILM flap in place, so usually bimanual surgery plus PFCL is used to increase the success of the surgery. Amniotic membranes are used similarly in these cases also. Preferably it should be bimanual and under the PFCL. Lens capsular flap technique is also used to fill in the macular holes. In the phakic eyes, after doing the phacoemulsification and implanting the IOL, you can harvest the anterior lens capsule during the capsular access. But in cases of the pseudophakic eyes, when there is no remnant of, or you cannot use the anterior lens capsule, you can use the posterior lens capsule. But it has been seen that the anterior capsule flap has a better closure rate compared to the posterior capsular flap. Autologous serums can be used during the surgery, and in this the serum is injected directly onto the macular hole. So this is a video of the patient who underwent ILM peel in elsewhere, and then there was a recurrent opening of the macular hole. So after putting the dye, there was no ILMs, fluid gas exchange was done. And after doing the exchange, a drop of serum was put directly over the hole. And then the FX was completed, and this is the post-operative picture at the 2 months and at 6 months. So this was a case which was operated for macular hole, but there was recurrence with the macular folds and this PVR changes. So after removing the membrane over the macula, even the peripheral fibrous tissue, it has to be tackled, else you will not get the closure of the macular hole. Once all the traction is relieved, the macular hole, it closes by itself. There was no need of any transplant of the ILM from the same site or the anything. Just the milking of the fluid and the macular hole was closed. And this is the post-operative picture of this patient at day 1. This was a case where there was anterior PVR which was not letting the macular hole to close. When the dye was put, there was tits and bits of ILM which was remaining. It was peeled off, the PFCL was put, rest of the membranes were removed, relaxing retinectomy was done, and after it was done, the macular hole closed. Now, neurosensory retinal graft. In this case, the harvest site is usually the superior to the superiotemporal arcade, and in this, yes, you always have to do the bimanual surgery under the PFCL. The most common complication seen is the graft displacement regardless of the tamponading agent. So this is the one case. This is the preoperative picture. You have to use the 41 gauge needle to create a bleb. Do the endolaser surrounding the bleb. Cauterize the inner margin, and then the flap is created. The neurosensory graft is created. Cauterize the bleeders. And then put the chandelier, put PFCL. After putting the PFCL, you have to cut the last hinge of the neurosensory graft. It is moved from the harvesting site up to the macular hole. Touch-up endolaser was done, fluid air exchange followed by the silicone oil tamponading. So this is the post-operative picture of this patient. Now, if suppose you have nothing to do, sometimes the simple maneuvers can lead to the closure of the macular hole. In this case, under the fluid, the subretinal fluid was drained. The major tip here is you should not touch the RPE. It should be always at the edge of the macular hole, because inadvertently if you touch the macular hole, you will create hemorrhage and it can later on lead to the formation of the CNVM. So always your tip should be at the edge of the macular hole, and if it is a patulous macular hole, it will close automatically simply with these maneuvers. Now this is the last case in which it was the recurrent retinal detachment because of the reopening of the macular hole. There were no peripheral breaks, nothing. So in this case, the fluid was drained through the macula only. Periphery was again examined, ILM was again stained to see. Fluid air gas exchange done. The residual fluid from the macular hole, it was drained under FAX. And we could see that it is closing slowly. The dimension of the macular hole was decreasing. On table, there was a closed macular hole after draining all the fluid. So because the RP is very unhealthy and it was the third recurrence in this patient, so the endo laser to the edge of the macular hole was done in a hope that it will create some adhesion and there will not be any fluid again into the macular hole, and again the touch-up laser in the periphery was done and the case was closed. Thank you so much.
Of macular hole, and I thank you for presenting his work also. Vatsal, you had a question?
I had a comment. See, in last 10 years, we had about 10 macular holes which I had operated and not closed. So over the years, what technique I have developed is that we have now SwepSource OCT, so you can do OCT after 4 hours of surgery also, and it gives a beautiful image of the whole area. So many times the patients do not maintain position. So what I have done is just do OPD-FG with C3F8 gas. There are two rationales that if patient has not maintained position, we insist on maintaining position and C3F8 remains for longer time. So sometimes hole may take longer to close rather than 5-6 days we normally use SF6. So at least 4 holes have closed with just OPD-FG, you know. And these are vitrectomized eyes, so I think putting 1 cc C3F8 is not difficult.
You maintain position for 3 days or longer?
3 days, ma'am.
3 days. I think that's the general
So,
kind of.
but this is in cases of the primary macular holes. Sir, what is speaking about? But Vatsal, sir, this is about the primary macular holes. What you were talking about to inject the C3F8 and then giving the prone position. In the primary cases, na, sir? Yes.
Yes.
Hello. What are you using ordinary laser treatment in the laser of the macula? In laser of your macula? The endo laser of your macula.
Yes, sir.
Is it in the edge of the
Edges of the macular hole.
edge of the macular hole?
Yes, sir.
And what kind of laser are you using? Is the same green laser?
Same green laser, sir.
So you will induce a scar in the macula then?
Yes, sir. But when there is cases of pathological myopia, or when there is no RP, you are suspecting that RP is very unhealthy. In these cases, always the recurrence was because of the reopening of the macular hole only.
So you are assuming that the RPE underneath the macula is already non-functional. That's why you do laser treatment?
Sir, as a last resort, if there is always a recurrence and recurrence just only because of the reopening of the macular hole, laser can create the adhesions.
Okay.
Have you done any of these posterior staphylomas where they have these macular
Ma'am,
holes?
not in cases of posterior staphylomas we do. This was hardly 1 or 2 cases when there are many recurrences only because of that.
Okay.
So as a
Because-
last resort, when
Yeah.
nothing is working.
You wanted to remain in place. I thank all the participants, all the speakers who have come here so early in the morning and shown their beautiful videos and educated all of us. And I thank the delegates who have come and attended it also at this thing. And at this, we conclude this session. But I would request everyone to come up for a group photograph. Prashant, can you give this? I request Dr. Prashant to give Vatsal his plaque.
This is the second time I'm giving you, and next time you'll get this presidential
Anand.
decoration.
And I request Dr. Anand to come and give this to Paritosh. Remain over here for the group photograph. You got your plug? Okay. Uh, come, come, both of you also come. This is the fill-in process. Come. Come join us. Come. Come. All of you can come.